Hi, this will be the continuation of your discussion in pharmacology. So please be reminded of our disclaimer that this recorded lecture is only intended for the Level 2 students of the BSN program of Central Philippine University. This does not constitute any medical advice, and if there is any, the views expressed in the presentation are my own and does not express the opinions of any entity. The photograph and videos used in this presentation belong to the respective owners. If there are any concerns regarding the presentation, my email address is indicated on this slide. So this is a continuation of Unit 1 on our introduction. Remember, we have been talking about the pharmaceutic, pharmacokinetic, and pharmacodynamic phase. We have discussed about liberation and absorption. Now we will proceed with distribution. So as we know, or if you can recall, distribution is the process of distributing the drugs to the receptor sites, okay, where they can act on. So when I talk about distribution, these are taken care of by your blood and your blood vessels. So what are the factors that can possibly affect drug distribution? So one is the solubility and ionization of the drug. Okay, try to recall which drug is easily absorbed or distributed. Is it the lipid soluble or the non-lipid soluble? And then also try to answer which drug is easily absorbed and distributed. Is it the one which is ionized or the non-ionized? Second, perfusion of the reactive tissue. Okay, the rate of the blood flow to where the drug is being administered would affect its distribution. For example, if the drug is administered subcutaneously, its distribution is expected to be slower compared to the drug administered intramuscularly because blood vessels, okay, or blood vessel endings are minimal to the subcutaneous tissue compared to that of your intramuscular injection, which has access to your blood vessels. Then, drug affinity. When I talk about drug affinity, this again refers to your protein binding. So take note that protein-bound drugs are not lipid soluble. So what do you think will be the implication? Can it be easily distributed, or is the distribution slowly? Okay, or slower if it is protein-binded molecule. Now, let us talk about the protein binding drugs. So let us recall that the protein drug complex is considered to be large and cannot enter the capillaries. So meaning it's large, it cannot enter the capillaries. What do you think will happen to distribution? Will it be faster or slower? The tendency is that when the protein drug complex, or for example, a large proportion of the drug is bounded to the protein, the tendency is that for this protein drug complex to be inactive. Okay, as mentioned on the slide, bound molecules are considered to be inactive because, again, those bounded molecules are large and cannot enter the capillaries. However, those that are not bound are considered to be the active component of the drug inside our body. Hence, they are also referred to as the free drugs. They are the ones that go to the blood vessels and the ones that reach the site of action. Because take note, your blood vessel is still not the site of action. There are different receptor sites where you expect the drugs to act on. Then, the competition on the binding site may decrease effectivity of one drug and increase toxicity of another drug. Okay, now let us answer this question. What if there are two protein binding drugs that are administered? Again, what if there are two protein binding drugs that are administered? Take note that the binding or the protein binding capacity of the drugs varies. So how about if there are two protein binding drugs that are administered? What do you think will happen? So these two drugs would compete to the binding sites. Okay? Drug A and drug B, for example, who are highly bounded to protein, would compete on the binding sites. And with this competition, there is increased possibility for the free drug to be released in circulation. Let's say, for example, as your textbook would point out, if drug A has 95% affinity to protein, and then drug B has, for example, 80% affinity to protein, drug A will be able to capture all the protein binding sites. And then drug B, instead of its some components binding on the protein site, will become free. There will be more parts of drug B that will be free compared to drug A. With that, drug A becomes less effective, they are bounded to proteins. Drug B, on the other hand, becomes more toxic. Okay? Drug B has a higher tendency to become more toxic because there are more free drugs released into circulation. Okay? Because more free drugs released to the circulation, again, the risk for toxicity. That's why we need to be mindful if there are two protein binding drugs that are being administered at the same time. Okay, they will compete on the protein binding sites, increasing the risk for toxicity. Now, what if the patient has decreased protein levels? If you can recall, the role of the protein is that the protein binds with some of our drugs and then it inactivates some of the drug components. So what happens if there is a decrease of number of protein binding sites? There will be an increased amount of your free drugs. If there's an increased amount of free drugs, what will happen? It will decrease, it will increase the risk for toxicity. Okay, so what if the patient has decreased protein level? We refer to that one as hypoalbuminemia. Albumin is protein, so hypoalbuminemia. If there is decreased protein levels inside the body, there will be increased risk of toxicity. So what is supposed to be done by the healthcare practitioner, or what is supposed to be done by the physician? If your patient, okay, has decreased protein, one thing that we need to do is to correct the protein levels of your patient. That is by administration of your albumin, for example, and then encouraging your patient to increase protein intake. Or if not, we need to decrease the amount of the medication being given to the patient. So what are the conditions that usually leads to decreased protein levels? One is your liver problem, then you have your kidney problem, you have your patient who is malnourished, and all the adult with multiple chronic illnesses. These are patients who are at high risk for decreased protein levels. Then, next question, can the drug cross the brain? If you can recall the discussions in anatomy, there is a tight junction on the epithelial cells of our brain. This tight junction is what you refer to as your blood-brain barrier. So your blood-brain barrier protects the entry of foreign substances to our brain. Okay, 98% of the substances available in the market could not enter our brain tissue because of your BBB, okay, your blood-brain barrier. So the question is, can the drug cross the brain? There are few drugs that can cross the brain. So what do we mean by that? If your patient has a brain-related problem, a brain-related infection, a brain-related disorder, you need to use drugs that can cross the blood-brain barrier. Example of which is your benzodiazepine. Okay, take note, benzodiazepine. One particular example under that category is your diazepam. These are low molecular weight drugs. They are highly lipid-soluble drugs. They are able to pass through the blood-brain barrier. Later on, we will know that diazepam is used to manage anxiety. Diazepam is also used to manage seizure. When I talk about seizure, the problem of your patient with seizure is that there is hyperactivity inside the brain. Okay, because of that hyperactivity, we need a drug that can able to enter your brain. Hence your benzodiazepines. If your patient also has meningitis, infection of the meninges, okay, we need drugs that can possibly cross the blood-brain barrier for that matter. Then, the question is, can the drug cross the placenta? Okay, placenta, that very tissue that allows the perfusion of blood from the mother to the fetus. Can the drug cross the placenta? Yes, it can. Okay, and this drug could possibly affect not only the mother but also the fetus because it can cross the placenta. So, what do we mean by that? If you're pregnant, if you have a patient who's supposed to be pregnant, you do not just give drugs to your patient. That's why one assessment that we commonly ask our patient is that, when was your last period? That very question about your last period would already give you a hint if your patient is pregnant or not. Okay? Why? If the patient is pregnant, you need to weigh the risk and the benefits. Okay? Risk and benefit ratio. Why? On the first term of pregnancy, spontaneous abortion may result from some drugs. Second term of pregnancy, or second trimester, of pregnancy, spontaneous abortion or teratogenesis. Okay? Failure in the formation of your organs or abnormality in the formation of your organs. Because there are some drugs which are considered to be teratogens. Teratogens toxic to the fetus. Then, third trimester, there may be a problem with fetal growth and development. That's why if a pregnant woman ought to take a drug, it needs to be with a consult of the physician, even if this drug is over-the-counter medication. When I say over-the-counter medications, these are medications that can be bought, even without the prescription of your doctor. Okay, so pregnant patients needs to be extra careful. Some of the medications that can possibly cross the placenta are your heparin, protamine, and then insulin. Heparin is an anticoagulant. As an anticoagulant, it increases your risk for bleeding, so it can make the fetus bleed. Protamine, okay, protamine is in fact the antidote for your heparin. Insulin, insulin is used for the management of your blood sugar problems. So, if your patient would have insulin later on, if insulin goes to the fetus, okay, one risk is hypoglycemia or maybe later on rebound hyperglycemia. Okay, you'll learn more about that in your maternal and child abnormalities also. Okay? Then, can drug cross the breast milk? Okay, can the drug possibly cross through breast milk? And then the answer for that is a big yes. Okay, that's why if your patient is taking over-the-counter drugs, prescribed medications, herbal supplement, or supplementary drugs, they need to inform the physician that they have been taking these drugs if they want to nurse their babies. When I say nurse, if they want to breastfeed their babies. Okay, so if the patient, for example, is using illicit drugs, the illicit drugs could possibly travel through breast milk and then could also make the child addicted later on. Okay, that's why, again, the general advice for pregnant and lactating mothers is consult the physician before they proceed with any medication. Next, metabolism or biotransformation. So this is the process by which the body inactivates the drug. If you can recall the previous discussion, our organ for metabolism is your liver. Okay, so chemical changes into the drug in such a form that it can be excreted. Okay, what your liver does is to make the lipid-soluble drug water-soluble. Water-soluble, hence it can be easily excreted by your kidneys for that matter. So, as mentioned, the primary site for metabolism is your liver. Once the drug passes through that biggest gland of our body, your liver, it inactivates, okay, or it becomes inactive metabolites and they become water soluble. We have what you call your cytochrome P450 system or the P450 system, which enables this process to occur. However, take note that there are drugs that whenever they pass through the liver, they become more active. But the general rule among our medications is that once they pass through the liver, some of it is being inactivated. Not only some, but a big amount of it. That's why we refer to it as your first pass effect. Then, what are the factors affecting your metabolism? One is age. Okay? Decreased liver function in aging process may result for increased risk for toxicity. Okay? As we have mentioned earlier or in the previous lessons, once your liver function is decreased, the capacity of the liver to metabolize is also decreased. Okay? Because that capacity to metabolize is decreased, only few parts of the drugs are inactivated. Then, more parts become active. And because of that, increased risk for toxicity. Okay, nutrition. When I talk about nutrition, remember protein. Okay? Whenever we have problems with protein, you will have problems with drug metabolism also. Then you have insufficient hormones. So if the hormones are insufficient, these hormones may not be able to combat or counteract the effect of the drugs, risk for toxicity. Now let us talk about half-life. When I say half-life of a certain drug, it is the time it takes for the amount of drug in the body to be reduced to half. Okay, the keyword is half-life, to be reduced to half. Okay, so the time it takes for the drug to be reduced to half. Let's have an example. For example, we have this drug X, and the drug X here has a half-life of 12 hours. So if you would look at the example, on the first time you administer the drug, it will be 100 milligrams present in your body. After 12 hours, if 12 hours is the half-life of the drug, it will become 50 milligrams. After another 12 hours, it will become 25 milligrams, reduced to half. After another 12 hours, it will become 12.5 milligrams, okay, reduced to half again, okay, until the drug is fully eliminated out of the body or until the drug is in significant levels inside the body. What is the implication of this half-life? Your half-life will be able to determine until what time or until when the drug will be effective inside the body and until when the drug would have an effect in the body. For example, if we are determining drug withdrawal, okay, we're talking about illicit drugs, okay, we will be able to determine that, for example, within 36 hours, this drug still remains inside the body. So we expect withdrawal reactions from the patient within the next 36 hours. Okay, or for example, we're talking about paracetamol. We can say that we need to administer paracetamol every 4 hours based on its half-life. Okay, so that's how significant your half-life is. Now, let's talk about implications. What if there is a kidney or liver damage? What do you think happens to the half-life? To answer this question, we need to recall the role of your kidney and the role of your liver. Okay, kidney is the main organ for excretion. Liver is the main organ for metabolism. So what do you think do they do? Okay, they would eliminate the drug. What about if these two organs are damaged? Will they be able to eliminate the drug effectively? No, they will not. Okay, so if there is kidney or liver damage, what do you think happens to the half-life? Does the half-life become shorter or does it become longer? The tendency is for the half-life to be longer because less drug is being metabolized by the liver because it's damaged, and less drug is being excreted or eliminated by the kidney because it's also damaged. So what if this drug's half-life is prolonged? There will be an increased risk for toxicity because more drugs are staying inside the body. Take note of that. Now, by knowing the half-life, the time it takes for the drug to reach a steady state of serum concentration can be determined. Okay, so again, by knowing the half-life, we'll be able to determine the steady state. What do you mean by steady state? Your steady state is the state wherein the drug being administered and then the drug being eliminated is already equal. Again, it is the state wherein the drug administered and the drug eliminated is equal, meaning you are maintaining the therapeutic range of the drug. Picture that you will just administer drug A and then it is not followed by a second dose. The drug A will undergo your onset of action, peak action, and then it will slowly go down. Okay, remember, that's only your duration of action. However, if you would want that drug to have continuous effect inside the body, such as your maintenance medications, you need to administer a second dose. Okay, and that second dose can be determined also by your half-life. Okay, when to administer the second dose is administered or is determined by the half-life of medication. Okay, so let's have your loading dose. When I say loading dose, this is the initial dose which is larger than the dose intended to give a therapeutic effect. Again, it is an initial dose which is larger than the usual dose and it is intended to give a therapeutic effect. So the purpose of that is that it is significantly higher dose to reach the steady state. Okay? For example, phenytoin. Okay, phenytoin. Phenytoin is a drug used for seizure control. It is an anticonvulsant. But if your patient is at high risk for seizure, imagine if I will just follow the half-life of phenytoin, it would take 3.5 days for phenytoin to have its steady state. So what happens? I give phenytoin right now, my patient's seizure will stop. After some hours, my patient's seizure might recur. So for us to ensure that my patient will have a steady state of phenytoin on the initial stages, we usually give an initial loading dose. For example, the initial loading dose could be 300 milligrams right now. And then we will be giving 100 milligrams twice a day. So the purpose of giving 300 milligrams as a stat dose, when I say stat, it is given now, okay, the purpose of that is to have a loading dose to maintain a steady state. Another example would be administration of your antibiotics. Okay, let's have, for example, cefuroxime. Your cefuroxime is an antibiotic. Specifically, it's a cephalosporin. Okay, we usually give it as a prophylactic antibiotic prior to surgery. When I say prophylactic, it is given to prevent something. Okay, in this case, since it is antibiotic, it is given to prevent infection. Now, as a prophylactic medication, for example, we would give cefuroxime 1,500 milligrams IVPT prior to OR. And then the succeeding dose of which will become 750 milligrams every 8 hours. So the purpose of giving the loading dose is to give an initial kick to your patient for us to maintain the steady state earlier. okay, for the patient's drug levels to be within the therapeutic range on the succeeding doses. So that is your loading dose. Then let's talk about excretion and elimination. So talk about LADM. Let's go to E. Your E is excretion or elimination. So elimination of metabolites of the drug or the active drug itself. So there are routes of excretion. The major that we know is your kidney. So let's talk about the skin, the bile, saliva, feces, lungs, urine. They could all be routes for excretion of your medications. But of course, primarily, it would be your urine through your kidney. So remember that your acidic urine, for example, promotes elimination of weak basic drugs. Okay, and then your alkaline urine would have the contrary role on that. Then kidneys. So as mentioned, kidney is the main route of drug elimination. So the factors that affect your drug excretion is one, your renal excretion. So if your BUN and your creatinine are increased, what do you think is the implication? Your BUN and creatinine are laboratories used to check for your kidney function. If BUN and creatinine is increased, that would mean that there is a problem in your kidney. Since there is a problem with the kidney, can the drug go out or does the drug stay? The tendency is for the drug to stay in our body, increasing the risk for toxicity. Hence, if there is renal damage, what happens to drug excretion? Drug excretion is said to be decreased. Okay? Also, on your renal excretion, you need to understand pre-renal problems, intrarenal problems, and then post-renal problems. When I say pre-renal problems, this involves problems about circulation to the kidneys. That's why it's referred to as pre-renal. Kumbaga, it occurs before the kidney, pre-renal. Okay, so probably there is a narrowing of the blood vessel going towards the kidney. There is poor blood perfusion in the kidney. If blood is not going through the kidney, of course, kidney will not be able to function well. Intrarenal, when I say intrarenal, intra, within the kidney. So the damage is on the kidney tissue itself. Okay, examples of this is your glomerulonephritis. Okay, so when I say glomerulus, that's the basic unit of your kidney. Glomerulonephritis is the inflammation of your kidney. There is a damage internally inside the kidney. That's why it's referred to as intrarenal. Then you have post-renal. Let's talk about post, after the kidney. So after the kidney, you'll go to the ureter. So if there is a block in the ureter because of the ureteral stones, okay, you will have secondary kidney problems. Okay, or if there is a block there of a stone in your ureter, the urine made by the kidney will not be able to go down to your ureter, not able to go down to your bladder. So, will drugs be eliminated? No. Okay, because of that post-renal problem. Second, drugs. There are drugs that are quickly eliminated from the body. There are drugs which stays inside the body for long periods of time. Then we have your blood concentration levels. So the general rule is that the higher the blood concentration levels, the longer this drug stays inside the body, the longer that they can be eliminated from the body. Then we have the half-life of the drug. So you know the discussion on the half-life already. The shorter the half-life of the drug, the quicker these drugs are being eliminated from the body. So that is for your pharmacokinetic phase. If you can recall again, your pharmacokinetic phase is composed of your liberation, then you have your absorption, you have your distribution, you have your metabolism, and then you have your excretion. As we go along specific classes of medications, you will know that these different drugs undergo different durations of each of these phases of your pharmacokinetic process or pharmacokinetic phase. Then let's go to your pharmacodynamic phase. So your pharmacodynamic phase is the study of the biochemical and then the physiological effects of drugs. In other terms, what the drug does to the body. Okay? And that answers the question, mechanism of action, meaning how does this drug affect the body. Now, let's talk about some principles under pharmacodynamics. So you have intended, or the primary, and then the secondary effect. When I say primary effect, it is the intended or desirable effect. Okay? So when I say intended or desirable effect, it is the reason why it is being prescribed. Okay? It is the reason why it is being prescribed. Secondary, Okay, secondary effect is usually referred to as the side effect. Okay, sometimes it is desirable, but sometimes it is also undesirable. Okay, so the secondary effect is the unintended effect. Okay, this is the drug, the reason what we watch out for in the medication administration. The reason also why we need to monitor our patients after we administer the drugs. To give a clearer example on that, let's talk about the drug atropine. Okay, the drug atropine has several effects. Okay, the drug that I'm talking about now is atropine. Okay, let's picture a patient who will undergo endoscopy. Okay, when I say endoscopy, dear students, okay, when I say endoscopy, a scope is being inserted through the gastrointestinal tract of the patient. Okay, endoscopy. What we are visualizing there is the esophagus of the patient. So a scope will be inserted through the mouth of the patient, and then that goes towards the esophagus, and then possibly the stomach of the patient. Now, when my patient will undergo endoscopy, because a scope will be inserted, a scope is like a tube. Okay, it's like a flexible tube which is inserted through the esophagus, through the mouth of your patient. Because of the entry of this tube, we would want the mouth of our patient to be dry. Okay, we want the mouth of our patient to have decreased saliva because the saliva could possibly cause aspiration during the procedure. So one effect of your atropine is to decrease the saliva of your patient, to decrease the secretions of your patient. So in that case, the primary or intended or desirable effect of atropine if my patient is undergoing endoscopy is mouth dryness or the decrease of secretions on the oral cavity. That will be the primary effect. However, take note, atropine has a cardiac effect. Okay, later on we will know about sympathetic. So atropine has a sympathetic effect. Okay, that sympathetic effect could possibly lead to increased heart rate. Recalling your lessons in health assessment, increase in heart rate is referred to as tachycardia. So in this case, your tachycardia is considered to be a secondary effect. That is not the effect that we want to happen right now in the case of our patient. Okay? Okay, take note of that example. But on this second example, look at how it works. If my patient has bradycardia, okay, when I say bradycardia, recall, there is a decrease of your heart rate. If my patient has bradycardia, I will be giving atropine to this patient. The purpose of giving atropine to the patient is to increase the heart rate. In this case, the increase of the heart rate is the primary effect. That is our intended effect. And then the secondary effect would now become, okay, the dryness of the mouth. Okay, because our primary effect that we want to happen right now to the patient is to increase his heart rate. Okay, so for us to determine if it is the primary and then the secondary effect, we also need to understand the case of our patient. Okay, I hope that example somehow clarifies to you the primary and secondary effect. Now we have the term dose response and then potency. When I say dose response, it is the relationship between the minimum versus the maximum amount of drug dose needed to produce the desired response. So meaning, below this minimum and beyond the maximum, the drug may already be underdosed, not effective, or overdosed, toxic on the part of our patient. So we need the drug to be maintained between the minimum and the maximum amount of medications. Then we have potency, the amount needed to elicit a specific response. So for example, there's a certain drug that reaches this level, this will be the effect. Beyond this level, this will be another effect. Okay, so that is what you call as potency. Then we have your receptor theory. The receptor theory states that the drugs act on specific areas on cell membranes. Okay, this action is on your receptor sites. So the drugs would bind to the receptor either to activate or inactivate the receptor. So when I say activate the receptor, it can produce a response. When I say inactivate the receptor, it can block a response. So that simply means that when the drug reaches the receptor site, there are two possible options: for the drug to activate the receptor site or for the drug to inactivate the receptor site. So the activated enzyme systems could possibly decrease the cellular activity and then decrease the cell membrane permeability. that allows for the drug to enter inside the cell. Then you have your drug binding sites, commonly your protein, your glycoproteins, and then you have your proteolipids and also your enzymes for that matter. To this effect, so these are the phases affecting drug activity. So if you can recall earlier, we have your pharmaceutic phase or pharmaceutical phase, then you have your pharmacokinetic phase, and then you have your pharmacodynamic phase. So this is in order. It needs to be undergoing your pharmaceutic phase during administration. So the drug will be available for absorption to undergo your pharmacokinetic phase, and then later on your pharmacodynamic phase. So how the drug acts to the body. To understand further, let's know that there are 4 receptor families, okay? Just an overview of these receptors. So you have your cell membrane embedded enzymes, ligand-gated ion channels, then you have your G protein coupled receptors, and then you have your nuclear receptors or your transcription factors. So you have your cell membrane embedded enzymes. The binding occurs on the cell surface, and then the drug activates the enzyme inside the cell to elicit a response. Okay, that's why it's referred to as cell membrane embedded enzymes. Then you have your ligand-gated ion channels. So here, the drug spans the cell membrane, and then the channel opens, allowing for the flow of ions. This usually occurs among your sodium and your calcium ions. So later on, you will know that sodium has a specific function, calcium has a specific function, and opening these channels would allow for this function to occur. So your sodium and your calcium are referred to as electrolytes. Then you have your G protein coupled receptors. So there are 3 components for this receptor family. One is the receptor, the second is the G protein, okay, which binds with your guanosine triphosphate or your GTP, and then you have your effector enzyme or an ion channel. So in this case, the drug activates the receptor, receptor activates G protein activates the effector, hence the effect of the medication. And then you have your nuclear receptors or your transcription factors. These are found in DNA, and then among the 4 receptor families, this would have a prolonged effect. Then, the better fit to the receptor site means a more biologically reactive the drug is. So when I talk about receptor sites, it works like your lock and key model, meaning when the receptor site, or when the drug, best fits on the receptor site, the effect of the drug is more reactive. The drug would produce the effect that we would want to produce. On the next topic, we'll be discussing other terms such as your antagonist and then your agonist, your non-specific and then non-selective, and then the different categories of drug action. Thank you very much for your kind attention.